Hi, it's Dr. Centeno, and thanks for joining me this Monday afternoon here at You've Got the Power. So, today we're going to get into an interesting topic. Uh, and that topic I've talked about a few times directly, a few times obliquely, but has to do with the vast differences between spinal procedures between Clinic A, B, and C. And the only reason I'm bringing it up again is the fact that I'm on a couple of Facebook groups that are more patient oriented. I was more interested just to see what patients thought about all this stuff. And it's educational for me because it helps me to decide which topics to cover. As I see patients who are extremely confused about which end is up in this area of regenerative medicine, regenerative spine. And, I have to say, I am just blown away by how clinics continue to put out misinformation about what it is they do and how many patients are sort of biting on that lure, if you will, hook, line, and sinker, without first considering how to do research and whether or not what they're seeing is real or fake. So my hope is I can at least educate a few more people about this topic. So again, today we're going to talk about the vast differences in what clinics call regenerative spine and how you as a consumer can tell the difference so that you get the highest quality procedure possible. So again, I'll give a short lecture and then we'll go into questions. Anybody can ask about anything, whether it's this topic or anything else here. So let me share my screen here. And I'll go ahead and start the presentation. Okay, so let's get going here. Let me grab a pen. I like using the pen. So the title today is Consumer Alert. What's called regenerative spinal injections are vastly different between clinics. So patients know that we as physicians have board certifications and we specialize. And they generally understand the concept that specialist A, who offers a procedure X, is often performing roughly the same procedure as another specialist. Now, that seems to make sense, so let's interpret that a little bit. So, for example, a partial meniscectomy performed by an orthopedic surgeon in Chicago is similar to the partial meniscectomy performed by another orthopedic surgeon in Florida. And that's because orthopedic surgeons, PM&R doctors, interventional spine, those are all separate board certifications, and we should all be performing roughly the same procedures within a certain amount of room between those procedures. Obviously, physician A might do it slightly differently than physician B, but in general, you're getting a very similar procedure no matter where you go. So all of that makes sense to patients. Now, the problem is when you superimpose that kind of standardization on the stem cell Wild West. And in the stem cell Wild West, there is no accepted board certification and standardization for regenerative medicine. In addition, what's called a PRP or stem cell procedure in Clinic A is often wildly different than the same procedure where the same language is used to describe it in Clinic B. And today we'll forget about the wildly different things that are injected and called the same thing, like how PRP in Clinic A is very different than PRP in Clinic B, or how a bone marrow construct procedure in Clinic A is wildly different than Clinic B, or how a Wharton's jelly bottled stem cell, in quotes, procedure over here has nothing to do with a similar named procedure over there. But instead, we're going to focus on the vast differences between the actual spine procedures themselves. So we're focusing on just one small little part of a much bigger issue of lack of standardization. So these are the levels of regenerative spine injections here. You've seen this before because I've done this for more specific upper cervical care for CCI patients, but this one I've sort of watered down a little bit so that it applies to pretty much any spinal procedure. So we're going to go through these real quick. So level 0, these are blind injections, and basically these are ligaments, muscles, and tendons, and it's pretty inaccurate, right? If the patient's really skinny, you can get a little more accurate. If the patient's not really skinny, like many Americans, you're going to have a lot less accuracy here. Now, it's important to note that what you're seeing here, and on the right, we've got a prolotherapy clinic. On the left, we've got a chiropractic course on how to do these injections where they're claiming that they're injecting the facet joints. But it's important to note that this is below the standard of care for epidural or intrathecal injections, despite the fact that a lot of these clinics will claim to do those things. In level 1 clinics, so if level 0 clinics were just totally blind, level 1, there is some fluoroscopy used. So for example, this is from a Mexican clinic off on the right here. And you know, I know enough to be able to look at that, that image right here to know exactly what this guy is trying to do. Now, you would have a hard time identifying that, but I know that this is a TUI needle, so I know he's trying a blind but X-ray guided cervical epidural, and I can see that in the fluoroscopy image. I also know that he's not using any contrast to do it. So this is a common thing we'll sometimes see in these level 1 clinics. They're using fluoroscopy, but they're not using it to accurately define where they're placing this stuff. They're using it more as a way to document that it's going someplace close to the facet joint, or in this case, that it's going someplace close to the epidural space. But since contrast is not being used to confirm this stuff, this guy really has no idea whether or not it's going epidural, meaning the difference between placing this stuff around the nerves or epidural could be a millimeter one direction or the other, and without contrast, there's no way to tell. But this happens a lot. So this is a place where patients get fooled. They think that, well, they have an X-ray machine in there. I must be getting high-level injections, but they're actually getting low-level injections where a fluoroscopy machine is kind of bolted on to make it look better than it really is. Then we get to level 2, and here we're finally starting getting into where fluoroscopy is being used with contrast. So this would be an interlaminar epidural. You can see the dark contrast there, showing that this injection is in the epidural space. We know that because we can see little fat globules here and here. So we know that that's the epidural space, and this guy has gotten epidural flow. In this case, we've got a facet joint injection, and contrast will go up and down the facet joint like this. So we know that that person's actually in the facet joint. So the good news is that you're finally at a place where you can get things like simple lumbar and cervical injections, facets, epidurals, etc. You know that the stuff is being injected in those areas, and hopefully this provider is a specialist in interventional spine. The only area where you need to be a little careful of is a lot of the interventional spine guys really don't know how to treat the whole functional spinal unit. So they're just trying to take what they know, for instance, how to do an epidural or facet injection, and throw a little PRP in there or throw a little whatever in there. So it's not the highest level care, but it's definitely better than level 0 and level 1. Now, one of the things you need to look at when you get to these places at these levels is you want to make sure that the doctor who's actually doing this is qualified in interventional spine. So for instance, that is not a pediatric anesthesiologist like I saw in one Mexican website. Pediatrics hospitals have no interventional departments in the US, where things are much more sophisticated than they are in Mexico. So a pediatric anesthesiologist is barely going to know enough here to be dangerous. Same thing would seem to make sense that a spine surgeon wouldn't know how to do this right. He operates on the spine. You'd be wrong. Spine surgeons don't have this skill set. Same thing with orthopedic surgeons. Same thing with family doctors. Same thing with ER doctors or some other random specialty doctor like a cardiologist. They're not going to have this education level. Then we get to level 3, and we're adding in here the intervertebral disc as shown here. So you can see the needle going into the disc, and you can see the contrast showing that we are definitely in the disc. And then we're adding in the thoracic spine or the upper back here. And it's important to note, again, that these procedures can't be performed using ultrasound or blind. There's no way to get into a disc, for instance, in the low back or the thoracic spine or the neck. Using ultrasound, you have to have serum fluoroscopy with contrast confirmation. And the same thing we talked about before, you want to make sure that the doctor is treating the whole functional spinal unit, the ligaments, the nerve, the muscles or the stabilizer muscles, disc, facet joints, etc. Then we get to level 4, and that's where we're adding in these rarefied injections of the high upper cervical spine and other things like the anterior longitudinal ligament in the cervical spine. And I put here as a minimum requirement, the doctor for C0, C1, and C1-2 has to have done a couple hundred of these, and they need to do them at least a few dozen times a year to maintain that skill level. And that's very, very few US physicians that meet that criteria, as we've talked about before. And then we finally get to things like PICL. So what are the top red flags that you as a consumer of these things can look at to try to find when you should be concerned? And I'm going to give you a few things here. The first is that there's a focus on what's injected and not how or why it's injected. And I just saw that on that same Mexican website I was just looking at. I tried to find how it was they were doing what it is they were doing in the spine on their website. I really didn't find anything. I found a lot of focus on what was injected, but not on how it was injected. I finally found on their Instagram page a picture that seemed to show a guy doing a fluoroscopically guided / blind injection without contrast. So that answered my question, but I had to look for that. And then same thing with that same clinic and the others I looked at this morning, there are no actual images of the clinic using guidance for any of these injection procedures. And the clinic uses terms like facet capsule injections. That's another one. That's a dead giveaway that no one is injecting the actual facet joint. They're just putting the needle someplace close to the facet joint. Another dead giveaway, I'll go back to the Mexican clinic. They had a pediatric anesthesiologist, husband-wife team who were performing these procedures. There's not a pediatric anesthesiologist in the US I would trust to do that, let alone a husband and wife team from a Mexican hospital, meaning that pediatric hospitals don't really have interventional spine departments. And then another good one is really any clinic that's outside the US. Now you can get away with Europe sometimes here, but the US is where interventional spine started. And Australia, you're usually pretty safe with. Europe, you're pretty safe with. But if you're in Latin America or Asia, the likelihood that you're going to find a provider trained to do this stuff is slim and none, and slim's on vacation in Texas. Also, statements like this, that the cells will magically go where they're needed. They will not. And then finally, a a procedure that's priced by the number of cells delivered and not the complexity of the procedure performed. And so we see it on a lot of these websites, especially these Latin American clinics, where you pay X for 50 million cells and Y for 100 million cells and all these different things, but none of that makes any common sense because it's really the complexity of the procedure performed that makes the difference here. Meaning that's what takes the time, not getting a bottle with 50 million cells or 100 million cells. The time and the complexity is how complex is the procedure. So in summary, don't get taken by a clinic offering low-level procedures and confuse that with clinics offering state-of-the-art interventional spine care. Success is as much about what's injected and precisely how and where it's injected. So let me stop now and I'll start taking some questions here. We've got some background noise there, so I'm just trying to see if I can move the microphone a little closer here. So let me stop sharing that. And see if we've got any questions. Looks like we've got a couple. Duck P. Hi, I told you last video that my walking imbalance has improved a good amount from 2 weeks of laser tracking exercises. How long does it take to actually reverse subacceptal muscle atrophy? I don't know that we know that for sure, Duck P, but I can tell you that if you're looking at the degree of atrophy that most people have, let's put it in the context of something we know, right? So one of those things that we know for sure would be if I put your whole leg in a plaster cast or fiberglass cast, and your whole leg was in that cast for, let's say, 8 weeks, and you came out of it and your thigh muscle was shrunken up 80% smaller. So only 20% the size of the other thigh muscle. Now, with that kind of atrophy, you would know intrinsically that it's going to take you months to get that back if you're lucky. If you're not lucky, 6 months to a year. So it's going to be the same thing. A lot of patients we see have anywhere from 60 to 80 to 90% atrophy of those upper cervical stabilizers. So it's going to take at least months if you're lucky. And if you're not lucky, it could take longer. Duck P, can disuse muscle atrophy be reversed if there's only very mild fatty infiltration? No one's 100% sure about that yet when it comes to deep spinal stabilizers. We would all love to believe that it can be, but we don't know for sure yet. Duck P, what do you typically recommend to patients who need to strengthen deep neck flexors? There's a specific set of exercises that were developed by Carolyn Richardson out of Australia. And they're called deep neck flexor exercises. They use a little bladder-like thing. It looks like a blood pressure cuff. You try to press on the blood pressure cuff while you're in the supine position. So you'll probably want to try a physical therapist that advertises that they know how to do that type of thing. Or you can reach out to Carla, and she'll see if she can find you an IPA physical therapist. Duck P, for the CCI laser tracking exercises, if I'm correct, they only work proprioception, or do they actually regrow suboccipital muscles slowly? Probably both, but certainly proprioception would be a big part of that. Fatchin, the right alar is responsible for overhang on the left side. Opposite. It all depends on what's stable and what's not stable. It's actually ipsilateral, usually, meaning the right alar would be responsible for right overhang, but it also depends on what pieces of the whole structure are stable and not. Kimmy, DMX shows 3.7 left overhang and 6.5 right. Do you ever inject this one side? Yeah, well, that's probably loose on both sides, so we generally will inject both in that case. Kim, C2 axial sponge rotation is 22.9 right, 22.3 left, something PICL addresses. Well, it can't be both sides. Do you mean with left lateral bending, it's 23, and with right, with right, it's 23, and left, it's 22? I'm not quite sure how that is working, but if it's a rotational instability, posterior PRP is very unlikely to work. That only works about 1 in 5 times in our experience. So while it may work, it's just very unlikely to be effective in dealing with dealing with rotational instability at C1, C2. But I would need to know a little bit more about what it is you're telling me there. It's been advanced by Harry Winston. I've read your blog about this. I have a friend in the US who had very serious issue for this type of treatment from someone who wasn't even a real medical doctor, which required a hospital stay. What's being done about this issue? Yeah, I think what you're talking about there is naturopaths that are doing these procedures, and/or in a couple of states, chiropractors are doing them. We're also seeing nurse practitioners and physician's assistants who are trying to do them. So what's being done about this issue? It's a great question. The answer is not nearly enough. It's the Wild West. And it's one of the reasons why I do this show so frequently is because we're seeing lots and lots of people get hurt. In fact, I've been called as an expert on 14 of these cases over the last couple of years, meaning a medical expert. And they continue to happen on a regular basis. People are really getting injured. Every once in a while, we'll see a medical board take action. But the biggest problems we've seen, for example, with the naturopathic boards is they're trying to constantly expand their practice scope. So they generally won't take action in these situations unless there's bad publicity. So that's what I've seen happen so far. Now, listen, any procedure always has risk, but we do our best to minimize that risk in a lot of different ways. And part of that is being a provider who can look at and work up when there's a problem. So one of the things I see when these non-physicians are doing these procedures is they'll frequently miss very obvious signs that there were serious problems. So something to consider, but to answer your question, not enough is being done. Jeannie, 55-year-old female, good health, no meds, early February, sudden onset of oral fullness in both ears plus tinnitus, hearing test perfect, a pentagram normal, bite did feel off, TMJ specialist said muscles, type, no obvious issue, suggested mouth splint in case I'm clenching, nucleocaritic x-ray, showed atlas off by 2 millimeters and C3 out of alignment, some improvement right ear in the past weeks, left side worse, another clue, weird left eyelid twitch when yawning for months prior. My gut tells me, and then it kind of cut out there, Jeannie, so I'll try to get you on the flip side here, see if there's any more down below. It's been advanced by Sherry Kopp. What would we look for when trying to get this type of treatment if we can't get to you? Sherry, a lot of that depends on what kind of treatment we're talking about. So we're talking about upper cervical treatment. That's something we only recommend coming to Centeno-Schultz Clinic for because there's not a place in the US that has enough experience in the upper cervical spine. If you're talking about just a general spinal injection procedure, then use those red flags that I put up there. Robert, perhaps a red flag to patients. I experienced a clinic who got a PRP kit, 100 ml syringe, a big cup that goes in a centrifuge, low-grade PRP. Yeah, I need to know what the final injection volume would be to give you a sense of that. Neil McKinnon, CCI patient here has been dealing with small left disc protrusion at 5'1", mildly impinged left S1 root for 1.5 years. Can you expand on what successes have been had with PRP in these issues? Yeah, Neil, usually what works well is an extradiscal treatment. So what that means is injecting outside the disc area into the ligament area, and usually platelet lysate around the nerve. Those are all X-ray guided injection and ultrasound guided injection procedures, X-ray guided with contrast. So that usually works well for that kind of problem, probably about an 80% success rate. Barbara, why do you have to use different locations for a second bone marrow draw in postmenopausal women to protect the bone to get better bone marrow? It's better bone marrow, meaning that we did that study and it showed that if you go back to the same area within a certain time period, usually 9 months, on a postmenopausal woman, not on a younger woman, not on a male, you'll have a reduced bone marrow yield the second time. And again, that's the kind of thing you should be looking for in these clinics, that they're doing that kind of research. A good example is that Mexican clinic I was talking about. I asked the owner of that clinic, can I have some safety data on these that were using umbilical cord stem cells? I got nothing. I got 5-patient COVID-19 thing. Nothing has been published by this clinic. They're not doing any research, et cetera, et cetera. So that's the kind of thing you all should be looking for wherever you go. John, I'm not from the US, so I have to ask what time frame would I need to prepare for in case of visiting for a PICL procedure, including necessary tests and eventual recovery. Yeah, for international patients, we normally recommend that they come in for the whole week. That's 5 days. So basically, they might get here on a Monday, be seen on a Tuesday, get treated on a Tuesday. And we usually like a few days before they go back home the first time. That's so that we can see them in the office if there's any issues or problems. Now, obviously, if you need to come back a second time and you know how you're going to react, then that can be shortened considerably. But that's more the first time of trying to get to know someone and see how they react. Regenix been advanced by Leonard. I've been looking into treatment in Mexico. Claims made by the clinic are incredible. You're saying that all clinics in Mexico are not a good idea. I would not go to a clinic in Mexico at this point, Leonard. No. Why, as an expert, would I stay away from clinics in Mexico? A number of different reasons. Number one is there's a much, much lower regulatory bar in Mexico. And for example, the clinic owner that I was speaking to didn't have any safety data on what he was doing. He claimed that the Mexican version of the FDA had already approved all of that safety data. Now I'm going to do a blog on that hopefully sometime this week. There isn't enough safety data to look at, so I'm not quite sure how that happened. The second reason I wouldn't go to Mexico is you can't get a U.S. physician to easily practice in Mexico. So you get the local population, meaning getting a Latin American license for a U.S. physician is difficult to do. It's one of the reasons why when we wanted to use culture expanded cells, we chose Grand Cayman because it was easy to get U.S. physicians licensed in Grand Cayman. And the local physicians are just not going to have the same training as a U.S. physician. A good example is if you're rich in Mexico, you don't go to a Mexican physician, you go to a U.S. physician, and you fly up north to see someone who is trained in the U.S. So no, I think Mexican clinics are in general a bad idea for that reason. Now, who knows? There may be a new generation of Mexican clinics coming that solve those issues, but I haven't seen one yet. So if I find one, I will let you know. Edward, for someone who has type 2A instability, you mentioned in a previous video that injecting the posterior ligaments could reduce instability. Which posterior ligaments are these? Yeah, so Edward, for 2A instability, it could help, but not guaranteed to help. So that's more transverse ligament and related to some of the posterior ligaments. So certainly no harm, no foul in trying these posterior ligaments. That would be things like the posterior atlanto-occipital membrane, or PAOM, the VDL, nuchal ligament, etc. That would have to be done under X-ray guidance with contrast. And you could also do some of it under ultrasound guidance. But if the transverse ligament is at all involved, that's only anterior treatment. So it's one of those ones where no harm, no foul, trying a good posterior treatment. You just want to make sure it's a good one and not just sort of stick the needle in there. And if that doesn't work, you'd swiftly move into anterior treatment. RE question about posteriors for type 2A. If we're just talking about injecting those posterior ligaments and not the actual facets, because they're healthy, does that require a DSA or is contrast enough? If the facet joints are a part of it, and they usually almost always are, 80% of the time, let's say 70% of the time, then you would need digital subtraction angiography to inject 0-1 or 1-2. You don't need it to inject 2-3, but in a type 2A, remember, we're talking about the 1-2 joint, so you're going to need digital subtraction angiography for the 1-2 joint because the vertebral artery is running just on the side there. It's been advanced by DB. I've had a bad back maybe for years. Is there any possibility that a bad back can cause neck issues? Sure, and vice versa, right? You change your posture and how you carry your neck when your back is bad. And we know that people with chronic neck pain also have their lumbar stabilizers go offline, which can cause back issues. Edward, is upper cervical prolo as an injectate any riskier than PRP in the upper cervical area? Yeah, much, much riskier. Remember, prolotherapy works by a chemical damage to the local tissues. So it's a micro damage technique. So you're injecting a solution that causes damage to the local tissues so that you kick off an inflammatory healing response, hoping that the inflammatory healing response fixes more than the small amounts of damage that you do. But that solution, if injected into an artery or a vein, would destroy the artery or vein and or destroy the structures where the artery would go. So you've got the vertebral artery in the upper cervical spine. If you inject prolotherapy solution, 12.5% dextrose, some clinics use Marcaine, which is an anesthetic, and normal saline, you're going to stroke that patient out and give them a permanent brain injury. So yes, whereas PRP may or may not cause problems, depending on if it has any clots in it, cervical prolo injected into that vertebral artery is a bad day for everyone and a really bad day for you as the patient. Dave, off topic, what's the wait time for a virtual consult? Would a DMX in advance help you with trying to diagnose? I don't know the answer to that. Let me put Carla's info below. I'll put that in the comments. And you can reach out to Carla and get the estimate for that. Now, I'll be off for 6 weeks, but I will be doing consults twice a week virtually during that time. So nothing will change there. Neil, can extradiscal treatment be done at the same time as PICL? About 80% of the time, the answer is yes. A lot of that depends on what the patient can tolerate. So some patients can't tolerate 2 areas being treated at once, but if you're that kind of patient that can tolerate it, we do that all day, every day when we're seeing PICL patients. Ginny, sorry my message cut off. That was pretty much all. Wondering if additional imaging other than x-rays would be best. Have you treated this? Your thoughts on a predicament would be greatly appreciated. Yeah, so x-rays, MRIs, all of those things. I think you were talking about this ear fullness problem. You saw an upper cervical chiropractor. Things seem to be off. So if we really wanted to get the quickest amount of information, it would probably be a digital motion x-ray or DMX, a cervical DMX, to try to see if there's any instability. Now, we may miss it on the DMX. We may need other types of imaging. But if you're thinking this could be CCI related, that's a good place to start. And then we've got to get you into a virtual consult where we can have an expert try to see which end is up there. Regenerative been advanced by Lloyd. Are the prices for these procedures at the types of clinics you're talking about much cheaper than a good U.S. clinic like yours? Yeah, Lloyd, I think that's one of the reasons why a lot of people go to these vastly inferior clinics is pricing, right? They're like, so I'll give you an example. I was on that Mexican website this morning just trying to get a sense of what it was, because I'd only really seen it on social media. I hadn't seen their website, hadn't seen their Instagram and social media feeds outside of Facebook. So I wanted to know what the pricing was like. And that's when I discovered they were pricing it based on the number of cells you got, right? Because the vast majority of what they do is just a simple IV. So the focus is on the number of cells. So I looked at those prices, and those are certainly cheaper prices than what you would get in a US clinic. But what you're getting is not what you would get in a US clinic. So it's like 6 of one, half dozen of the other. It's a little bit like saying a Chevy Malibu is the same as a Chevy Suburban, or a Lincoln Continental, or a Cadillac, or a BMW. They're both cars, but there's a reason why the Chevy Malibu is much, much cheaper. There's a lot of corners that were cut in making a Malibu. It's the same concept here. There's really no difference. Zaki, if I'm not mistaken, that cervical instability may cause scar tissue to develop in the vagus nerve. Is there any way to slow down damage? I don't think necessarily scar tissue as much as you could, all the chronic irritation could damage the nerve. So that's what we've talked about here a number of different times. And that is trying to get, if you do have instability, trying to get treated long before you get into a clinical situation where you have damage in the nerve and these problems become baked in. Zaki, also, were there be any regenerative clinics in maybe New Zealand and Australia in the future? Any experts we suggest in this region? Depends on what we're talking about there. There's a Regenix provider in Australia, Kevin Bowney. He'd be a good place to start. If we're talking about CCI, the answer is no. If we're talking about just in general regenerative medicine, Kevin Bowney in Australia would be a good place to start. That's to go to Regenix, REGENXX.com. And you can take a look at Kevin. Kevin does mostly more simple spine and really great peripheral joint work. Amity, can PICL still be helpful after 1-2 years of ALR injury? Yeah, Amity, I would say on average, the average person walking the door with a 7 out of 10 success rate for a PICL is more along the lines of about 5 years out from onset of symptoms, somewhere in that vicinity. So that would be actually really good for a patient with alar ligament-related instability. Edward, for 3 out of 10 or so that don't respond to PICL, we can start going backwards and doing posterior prolo for type A-ish instability. So Edward, it's important to note that we almost always treat the posterior and the anterior at the same time. So there'd be no reason to go backwards. That would have already been done as part of PICL. Jonas, would either hyperbaric oxygen therapy or intermittent hypoxia training post-PICL be helpful in healing ligaments? Jonas, no one knows at all clinically on this one. So I always tell patients, at least on the hyperbaric oxygen therapy, it's probably not going to hurt. I can't tell you that it's worth the money you would spend on it, but if you want to give it a shot, go for it for sure. As far as intermittent hypoxia training, I don't think that's going to be effective. That's Carla's email if you need that. Edward, would you trust docs outside of Regenix to the nuchal and interspinous ligament, not talking the actual facets with C1, C2, use contrast of flora, presuming the ligaments are lower risk? Yeah, so midline upper cervical work at C1, C2, if someone's using contrast and using fluoroscopy, is not going to be high risk. So that's something they can definitely do. Now, they're going to be able to do the PAOM. That's the deeper ligament right there. No, they're not going to be able to touch that with a 10-foot pole, but at least they can do those posterior ligaments. And I think there's no harm, no foul in trying that. If you've got a competent provider who is using that imaging, understands how to use it, they can do that quite safely. And that way you can do that once or twice and see if it's really moving the needle for you. If it's not, then you probably need to go after that transverse ligament directly. Sean, is it common for golfers to get cervical instability to the amount that they rotate? Not that I've seen, Sean, no, but certainly if you're predisposed to this or you had an injury that caused rotational instability, the kind of rotation you need with golf is not going to be helpful. It's going to be like bringing gasoline to a bonfire, so to speak. Raul, thank you. REDMX, is there a difference between DMX machines, some machines better than others, or DMX are the same, given the same results images? Well, I can't say that they're exactly the same. We've certainly seen through the years that some DMX places just do a better job. I can tell you that there are two different machine types out there. One is an older DVD style machine, and it has about half the resolution of the newer machines. For example, you probably know that if you try to put a DVD player, and there's not many of those around anymore, but if you did this on an ultra high def or even a high def TV, it's going to look weird, right? It's not going to look the same that you're used to when you're watching Netflix at 4K or even at HD. Same thing here. We have DMX machines that are so old that they were made in the DVD era. And we've got newer DMX machines that have been made since 1280p HD came into effect. So that's the biggest difference between the machines. You want to try to find one that doesn't output a DVD file, but that outputs a computer video file at HD. And then, we've, like anything else, we've got DMX centers that do a great job, some that do an okay job, a few that do not a great job. So we've tried to keep a list of the better ones. I wish I could say that first name competently, Sagatu, but I apologize if I butchered that. Do you see POTS dysautonomia issues with people who have cervical stenosis or loss of lordotic curve, or something you see exclusively of people with CCI? We generally don't see dysautonomia in cervical stenosis patients, although it's not impossible, but that's usually not the case. Loss of lordosis, again, we usually don't see it, but it's not impossible. It's much more commonly associated with patients with CCI. Robert, overall, do most people tolerate PICL well? Not the outcome, just the procedure, abnormal post-swelling or pressure. Yeah, Robert, we now put people into two categories, and I've been doing this for about the last year or so. I'm not quite sure how often Dr. Schultz does this, but this is how I do it. I try to pick people out up front who I think are centrally sensitized, and then we go with a much smaller procedure, or I think I've talked about here, the less is more concept in those patients. Ever since we've been doing that, we've had very, very few of the really big post-PICL flares in my patient population. And once in a while we'll get one, but it's generally gotten rid of about 90% of those big, huge, prolonged flares. So I think if that's the way it's done, that can be managed. But I think what you're talking about is if you don't do that, you'll probably get 1 in 5 patients who have these severe long-term flare-ups that go beyond even a couple of weeks. But if you do it that way and you start to pull those people out of the population who are essentially sensitized, then I think that's very manageable. Sagatu, maybe. Lastly, can a virus of COVID-19 cause cervical instability or CCI? In other words, is there a virus-induced instability case in your practice? No. We have no data right now that shows COVID-19 can cause cervical instability. I can't even come up with a credible mechanism of how that would work. Now, it's not saying that at some point we may not figure that out. It's just right now we don't have credible evidence that that's the case. I think it's probably more likely that what we're seeing is someone who had prior cervical instability that wasn't symptomatic because of the inflammatory phase that the virus can kick off, sort of got to that point where they went from subclinical to clinical. And that's probably what we're seeing in that patient population. It's been advanced by Kyle. Are there any live stem cells and umbilical cord treatments that are offered in these clinics? How are the cells given by IV supposed to get to my neck and my knee? I was making plans to go. They said that's the way stem cells work. Yeah, Kyle, that's all fiction. So as someone who's published now about 50 peer-reviewed publications, written a bunch of book chapters, lectured every place from the Vatican to Stanford, meaning that's my CV. U.S. clinics don't have any live umbilical cord stem cell treatments available. Now, in Mexico, there may or may not be. I've got no way to test that to see if they're living or not. They probably don't either, meaning you'd have to look at an apoptotic study. My guess is that's not being done. They're probably getting the same simple live dead counts that the US clinics are getting. And you're right, there is really no way for IV stem cells to get to your neck or your knee. In particular, the problem areas are usually avascular or poorly vascular, meaning they don't have a great blood supply. So if these things hit your ride via the blood supply, they're not going to get where they need to go. So again, why are they offering IV? It's cheap for them. That's the reality. The reality is that I can have a low-paid medical assistant start an IV, whereas in order to get a doctor who would be trained, for instance, on how to put, I'm just making this up, let's say your knee ACL is loose and your meniscus needs treatment. To get that kind of doctor who is US trained, to get a license in Mexico and actually want to go to Mexico on a frequent basis to do those procedures would probably cost 20 to 30x over hiring a medical assistant to start an IV. So as you might imagine, if you're a clinic owner, and if I can convince you to come down to do a magic IV, why would I want to pay 30x, 30 times as much to have a US doctor come down there that actually knows what they're doing? I wouldn't. From a business standpoint, it makes no common sense at all. Now, as a physician, I'd never offer an IV stem cell treatment for someone's knee. It makes no medical sense. But as a business guy, it makes all sorts of business sense. So again, buyer beware. Raul, I've been able to help someone with pulsatile tinnitus. We've certainly seen patients who have pulsatile tinnitus, but not as their main symptom, or at least rarely as their main symptom. Those same patients have other things going on, headaches, neck pain, etc., and the tinnitus goes away as part of treating the upper cervical instability. But fewer patients whose only complaint is pulsatile tinnitus. Sean, what are the most common areas in the neck you'd be agitated by a golf swing? I mean, C1, C2 would be a big one, right? That's where 50% of cervical rotation goes or comes from. But as far as specifically, it's a good question. I don't know that I can answer that specifically. Jeannie, would there be, or where would one find a DMX X-ray? I'm in Rhode Island, an hour from Boston. Gina, I'd reach out to Carla. I had put her email address in the comments to see if we've got one up there to try to see what's available locally there for digital motion X-ray. Ulysses, we are talking about the vast differences between interventional spine procedures. Hi, doctor. Hope weekend was good. When does one know when one is overstretching the transverse ligament of the atlas and not stretching the back muscles, trapezius and such? How do we safely stretch them to know when we stop the stretch and overstretch transverse ligament? Usually, if you're overstretching transverse ligament, you'll know it. You'll get nauseous. So that's the best information I can give you there, meaning that when I think someone had brought up a couple of weeks ago, just a private email. Hey, do you do this transverse ligament stretch test that a lot of manual physical therapists will do? And the reason why I don't do it a lot is because I found that if someone really does have a transverse ligament problem, they throw up after you do it. So it's the same thing. You're going to get pretty nauseous if you are stretching the transverse ligament too much. Now, that's not in everyone. Some patients might have a loose transverse ligament and kind of gotten used to it being stretched. So it's a hard question to answer, but in general, there's usually pretty bad symptoms. Ginny, sure, Ginny, happy to help. Chris, is it possible for cervical osteophytes to go away on their own after instability issues are resolved? In general, Chris, we don't see cervical osteophytes go away like that. It's not to say it's not possible. It's just in general, that's not what we see. Okay, guys, so we're about 10 minutes away from the hour. So any other questions that I can answer here? I'm going to take a caffeine break. Either about this topic on the vast differences in clinics that claim to offer regenerative spine injections, or in any other topic that you have. Ulysses, do any Regenix places treat muscle atrophy, AK in the back or neck, related to spine? Yeah, almost all of them that do regenerative spine, and that's probably about 3/4 of all of the Regenix clinics, treat that deep multifidus atrophy. So that's a common one for Regenix clinics to treat on a day-to-day basis. Any other questions I can answer about any of these things? And I'll start just wrapping it up. And then if there's other questions that come in, I'll take those. So to wrap this conversation up, as I said, we have this vast difference between what one clinic considers a regenerative spine injection procedure and what another clinic does. And it causes a lot of you could call it consumer fraud, consumer misinformation. I'm not quite sure which label applies, but I can say that we have people who are paying top dollar for procedures at one clinic that aren't addressing the structures that are causing them problems, but they don't know it. And then we've got people at other clinics who are getting those structures treated as part of the therapy that's being offered. But consumers really don't know how to parse those two, and it causes a lot of problems. Phil, is a reliable clinical hands-on test for determining if alar ligaments are compromised? I don't know about a reliable test, but there's certainly some tests that you can use. Again, Phil, my concern there is if they are compromised, the person generally gets super duper sick and dizzy. So it's one of the reasons why I don't do that test and instead rely on the imaging. Chris, are you familiar with intradiscal ozone injections to treat herniations? If so, what is your opinion on its effectiveness? Yeah, the only place that's actually used a lot is in Italy. There are a couple people here in the United States that have an ozone generator, but they're not FDA approved, and they generally tend to get snapped up by the FDA because of that. Or they're using non-medical ozone generators. So listen, might it help a disc herniation? There's some reasonable research on it. I think a PRP epidural or a platelet lysate epidural will work just as well. So I don't think there's any reason to inject ozone, which is going to be higher risk in that area. Barbara, if swelling in bone is treated with bone marrow concentrate, will it be as good as new? I never make the claim that anything is as good as new. Can you get rid of bone marrow lesions, which are areas of edema or bone marrow edema on MRI? That way you can. Let's see. Thank you for your videos. In your video where you described DSA, you explained the importance of contrast very well. In December, I went to a provider who injected bone marrow stem cell into 01. I felt cold, tingly, prickly pain as the fluid entered my vertebral artery. Liquid traveled up into my skull brain. The doctor told the doctor to stop. He continued to press the plunger until that joint was injected. He injected the other side. Let's see, Ron, if I have more. I don't think I have more to that. But yeah, Ron, you bring up an important point, and that is that without digital subtraction angiography, there's no way to know whether or not you're injecting the vertebral artery, because the artery, because arterial injections so fast, you generally don't see them. They just happen in a split second. So most of the time, you don't see an arterial injection until you use or turn on the DSA. And it allows you to see that kind of stuff. So I appreciate you telling us that. And yeah, I mean, it's a big problem. We see it happen a lot. I don't think we'll ever really know how many brain injuries are out there from this kind of thing, because we have a lot of providers who are doing this. And it's really not a safe practice. So let me see I think you've got a question down there. Let me get Ulysses here first, and I'll come back to you. Ulysses, I remember when I got my neck injected last year with Prolog line from C3 to T1, all the solutions disappeared in the next few days, and the muscle spasms came back to stabilize the joint again. Yeah, probably that sounds reasonable. Robert, in a fusion in a joint or bone marrow adhesion, where's the white signal fat water? So Robert, it all depends on the type of MRI sequence. If it's a T2 sequence or a fat sat sequence, those are sequences where water is bright. So the bone is normally dark. So if you would see a bright spot in the bone on that type of sequence, then you would know that you're seeing swelling. Now, it can go the opposite direction if it's a T1 or proton density image. So a lot of that just depends on what we call the weighting of the image. So getting back to Ron, 2 major headache, stroke, and pain in brain lasting about 3 months, and finally some reduction in intensity this past week. No vitals were taken, no crash cart. Did not call 911. Could you please advise me what to do in this situation? I'm reluctant to see any more healthcare providers. Best I can tell you, Ron, is to stay out of clinics that aren't doing this at a high level. If they did get an injection into the vertebral artery, that's going to potentially cause a certain amount of brain injury. But I think regrettably, you went to the wrong place, right? You went to a place that didn't have digital subtraction angiography, maybe a place that wasn't really trained in how to do 0-1 or didn't have a lot of experience in 0-1, but claimed to. And so I think the biggest thing to do is to not trust healthcare providers, but just realize that you're in the Wild West here. And in the Wild West, you got to protect yourself, right? I live in Boulder, Colorado, and just down the hill from me, when my house was built in 1890, it was the Wild West. They were hanging people on Pearl Street. So people back then had 6-shooters, right? They walked around with guns. That's how they protected themselves from the Wild West. It's the same thing here. Patients need to be educated so that they can protect themselves from healthcare providers, in this case, that are wading into a pool that's far too deep. Daniel, hi, how do you believe ligaments improve when holding alignment for a long time, like 1 year or more? If you're holding alignment for a long time, that could mean that the ligament healed on its own, could mean that it healed enough where you're not getting too unstable and the muscles have been able to finally recover, or maybe you've been able to increase your activity level so that the muscles can recover. Chris, what's the best way to look at a televisit with you? That's to contact Carla. I had put her, if you go up in the comments, you'll see Carla's info there. Just contact Carla, who's my assistant, directly. Okay, guys, we're at the last 2 minutes before the hour here. Ron, thank you. It was Dr. Hansen, your old partner. Yeah, all I can tell you, Ron, is Dr. Hansen was never trained at our place how to do 0-1. And that's the best I can tell you there, meaning that that's a procedure that takes an immense amount of expertise. Dr. Hansen was in family medicine, learned how to do some simple lumbar stuff, but a 0-1 injection requires extensive in training, and as you've already brought up, digital subtraction angiography. So again, best I can tell you is don't lose trust in the medical care system. Just filter out the parts of the medical care system that are doing things that are way, way above their pay grade. Okay, guys, thanks so much for watching. I want everyone to have a great day. I will not be here this Friday. Then after that, I'm starting my 6 weeks. So I'm going to be releasing a video a week on YouTube and on Facebook. And then I'll be doing impromptu Facebook Lives once I'm over there on the other side of the pond. That's may or may not be great time for the US, but I'm trying to give some of the European watchers a chance to ask some live questions while I'm over there. But again, I'll be putting out one interesting video a week, so you'll be getting ongoing content from this channel. I just won't be doing lives with a Q&A like this for the next 6 weeks. But I will be popping on and doing some impromptu lives. Maybe they're in weird times in the US. So if you find yourself on Facebook and you see something come up, you can go, hey, that's Centeno, but he's over there on a goofy time zone. So anyway, you guys have a wonderful time. I won't be here this Friday because I've got a board meeting to go to. And then after that, I'll be releasing a video a week and then popping on periodically to do some lives. So thanks so much. And you all have a great week.